is not what happens to you. Experience is what you do with what happens to you. We're going to make a change in the protocol. I'm Eugene Krauss. I'm the chairman of the Department of Orthopedics at Syosset Hospital. We have a team that is really looking at the data.
And Surgeon-in-Chief of the Krauss Musculoskeletal Institute of the Peconic Bay Medical Center.
And I remember going home and thinking that I need to give up orthopedic surgery.
Greetings, everyone. It's a great pleasure to come to you today and to talk about another chapter in the remarkable story of the Caprini Risk Score. And this score has become very popular, but it's not because of Caprini. It's because of all of the wonderful people from around the world that have worked on the score, probed it, shown where it's good, shown where it's not good, shown where it needs improvement, and applied it in their own particular population. And today we see a stunning example of that coming from the Syosset Hospital, part of the Northwell system in New York on Long Island. And it's a remarkable story of creating a benchmark for thrombosis prophylaxis following total joint replacement. Now, I originally was contacted by Marianne Cronin to possibly use this score in their patients. And what happened next was the chief, Dr. Eugene Krauss, was in strong support of this project. And I'd like to talk about Dr. Krauss just a little bit. He's chairman of the Orthopedics at the Syosset Hospital and surgeon-in-chief of the Krauss Musculoskeletal Institute of the Peconic Bay Medical Center. Dr. Krauss is an associate professor of orthopedic surgery, Hofstra Northwell Health School of Medicine. Dr. Krauss's specialty is total joint replacements and has performed more, I think now it's up to 30,000 patients. He's a former aerospace engineer and is the designer and developer of multiple implants. Dr. Krauss is a consultant to the British National Health Service and has lectured extensively nationally and internationally. And under the created Krauss Foundation, Dr. Krauss has performed total joint replacement surgeries and humanitarian work in West Africa. Dr. Krauss is also an educator and has done motivational speaking. So we're very indebted to the leadership of Dr. Krauss and to his disciples, which you're going to see today, Nancy Dengler, Marianne Cronin. And Dr. Krauss, I'd like to turn the podium over to you. Welcome.
Thank you very much. That was a lovely introduction. I just want to mention that I always give the analogy that I may be the conductor, but I've got the best orchestra in the entire world. And so this is what I will talk about is a team effort. And I'm going to try to take you through an 18-year journey that we as a multidisciplinary team have taken together using standardized protocols based on medical evidence to dramatically reduce the number of VTEs in our program. So if you look at that slide, you see that there's three major inflection points. And what I would say to you is that my experience in life has been that an event occurs, and that can change the trajectory of your thought process and therefore where you're going. A famous 20th century British philosopher, Aldous Huxley, said that experience is not what happens to you. Experience is what you do with what happens to you. So I'm going to talk about the three inflection points and what we did that changed the trajectory of our outcomes. So if you go back to 2005, we had a DVT rate of 4.6%. Everybody got the same treatment. They were put on Coumadin, and we hoped for the best. And what happened in the following year, I did a patient who was very close to me. She was in her late 80s. I'd done a limb salvage procedure on her son 10 years earlier and dramatically changed the course of his life. And they had enormous confidence in me. And I said, it's not a problem. You know, I've done thousands of these knee replacements, and I did bilateral knee replacements on her. And 24 hours later, she died of a VTE, massive pulmonary embolus. And I remember going home and thinking that I need to give up. And instead, you have to say, well, okay, something went wrong here. and what can we learn from it? And clearly, we were using Coumadin on everybody. She had just started a Coumadin and she had a massive PE. And so we put together a multidisciplinary team. Marianne Cronin had already been started working with me at the time. She's a PharmD with a huge amount of expertise, knowledge, and interest in VTE prophylaxis and in hemostasis. And so we started to look at standardizing protocols and also looking at the data. And you can see that from 2005 to 2014, by instituting standardized protocols and looking at the outcomes, we were able to come from initially 4.6% down to 2.4%, and then as low as 0.3% in 2014. And then another event occurred in 2014. I was invited to give a talk for the British National Health Service on how to reduce infection rates in Great Britain. And somebody else gave a talk on how to reduce blood clots after orthopedic surgery. And he made an interesting point that although the literature was all over the place, whether we should be using Coumadin or Lovenox or compression stockings, nobody was looking at how soon did the patient start to ambulate. And we knew that in other areas, in general surgery and so on, people were anxious to get people out of bed right away. And so I came back from Great Britain and we put in a new protocol that everybody had to get out of bed same day of surgery. And because there's a shortage of resources, a shortage of personnel, there was every excuse in the world why that couldn't happen. And the protocol we put in was that if the patient is not out of bed that day, if my patient's not out of bed, then they need to call me on my cell phone. And as the chief, nobody wanted to call me on the cell phone. So all my patients got out of bed. And you see that we went from 1.6% down to 0.3%. And then we percolated along doing more complex patients. And we were hovering between 0.3 and 0.6%. And then another event occurred. And that was the fact that Marianne Cronin invited Dr. Caprini to visit us. And we started to talk about risk stratifying patients. We were doing more and more complex patients with multiple medical issues, multiple medications, and one size did not fit all. And we were blessed with the fact that Dr. Caprini, as our mentor, really encouraged us to look at this. Nancy Dengler, who is our research nurse with a huge amount of experience, again, she's a nurse practitioner in really looking at the data. And we started to do risk stratification. And you can see today we're doing 1,500 or 1,800 total joint replacements a year. And we're hovering at below 0.4% VTE rates on all comers. And probably that's among the lowest score percentage of any program in America today. So with that, I want to turn you over to Marianne Cronin, who is going to talk about how we went about creating the Caprini risk stratification.
Okay, so thank you for inviting us. So we know that risk stratification allows for patient-specific decision-making. Aspirin was first recognized as an acceptable option for thromboprophylaxis in 2014. In 2015, our orthopedic surgery department created a risk stratification protocol seen here. We basically used a binary principle of yes or no. So we chose out of the literature the most important of all of the risk factors that could lead to a post-op thrombosis after arthroplasty, which were active malignancy, a VTE within the prior year, inherited or acquired thrombophilia, morbid obesity, or if the patient was undergoing a staged bilateral procedure. Those patients received rivaroxaban 10 milligrams once a day or enoxaparin sub-Q based on the surgeon preference. We chose rivaroxaban at that point in time because it was once daily dosing. So the once daily dosing was very attractive in maintaining patient compliance. And it was also the first DOAC that was approved for all three indications: for preventing post-op VTE after arthroplasty, for treatment of VTE, and also for AFib. Our low-risk patients were given aspirin, 325 milligrams twice a day. That dose of aspirin was the most reported, popular reported dose at that point in time in orthopedics. And we started this risk stratification protocol knowing that this would provide both safety and efficacy to our patients after arthroplasty.
The orthopedic department was looking to improve our VTE outcomes, and this meeting with Dr. Caprini was an opportunity to collaborate on validating the Caprini Risk Score in orthopedics. So in 2018, we developed a protocol, implementation and validation of the 2013 Caprini score for risk stratification of arthroplasty patients and the prevention of venous thrombosis. This was a retrospective, institutional review board approved cohort study of all primary and revision THA and TKA patients. We looked at 1,078 patients. What we did is we compared our department risk stratification protocol to the Caprini Risk Score, or CRS. The CRS was calculated at 2 time points on admission and at discharge. And the reason we did the 2 time points is we wanted to incorporate into the protocol that the Caprini is a dynamic tool, that it's constantly evaluated during patient admissions. And we wanted to include any changes that occur during the patient admission and capture that at the discharge point. So the results showed that a CRS of greater than or equal to 10 was high, the patients were high risk for VTA. A CRS of less than 9 or equal to 9 was low risk for VTA. During the review, there were no deaths, no returns to the OR, and no significant difference in the bleeding outcomes between the 2 treatment groups, meaning the groups that got either a DOAC or received aspirin. So then we did a deep look at the VTE events that occurred, and 7 of the 8 events occurred in patients who were considered low risk and prophylaxed with aspirin. So then we compared our department risk stratification to the discharge Caprini scoring. And what it showed is that 7 of the 8 VT events were correctly identified as high risk with the Caprini risk score of 10 or greater, while 7 of the 8 patients were considered low risk by our department protocol. And the patient who sustained a PE was considered low risk by the department protocol, as well as the Caprini scoring system. However, the patient was ultimately found to have a thrombophilic defect when they were worked up after their pulmonary embolism. If this had been known preoperatively, the patient's score would have been 11. So both the department and the Caprini risk score would have been higher. So the Caprini risk score actually would have been accurate 100% of the time. So some of the major outcomes of this study were the occurrence of thrombosis was not influenced by individual high-risk factors, which is the strategy we were using, but the cumulative effect of multiple factors that increased the patient's Caprini score. The synergistic effect of individual factors of varying significance when combined yielded a predictive score which was much more accurate than any individual factor.
One of the benefits of using the CRS is that there is also a patient-friendly version that is available. And this is especially useful in elective surgery. The patient can fill out the patient-friendly version and bring it with them when they're having their pre-surgical testing, so that the nurse practitioner performing the history can incorporate all of those risk factors into the history of the patient. So after validating our study and having our Caprini cutoff of 10, we also decided to reduce the dose of aspirin to 81 milligram. At that point in time, there was much emerging literature showing that, as on the arterial side, aspirin 81 was equivalent in efficacy to aspirin 325 on the venous side, obviously with less GI adverse events. So we lowered the dose of aspirin to 81 twice a day for high-risk patient, for low-risk patients. And we also moved away prior to this from using rivaroxaban. We had found that some of our patients were bleeding more on rivaroxaban. There was better safety data with apixaban. And so we were using apixaban 2.5 twice a day for high-risk patients. However, within 3 weeks of reducing the aspirin to 81 milligrams, 2 patients developed a PE. obviously quite concerning to our team. And this sent us back to the literature, because as a pharmacist, I was aware of published literature that had shown that traditional NSAIDs, specifically ibuprofen, had been shown to interfere with the efficacy of aspirin 81 milligrams when prescribed for secondary prevention in cardiovascular disease. So could the same thing be going on with celecoxib? But intuitively, you wouldn't think so, because celecoxib is a COX-2 inhibitor, whereas aspirin is a COX-1 inhibitor. The literature was quite sparse, but when we combed through it, we actually found that all the studies that had compared looking at that interference had used doses of aspirin that were a little bit higher, around 300 milligrams. And when we tried to just pull studies that compared celecoxib with aspirin 81 milligrams, we found that there was indeed an interference that had been published in the data. And so when high dose celecoxib was administered in close proximity to aspirin 81 milligrams, the antiplatelet effect of aspirin was indeed compromised. So our real world outcomes of concomitant administration of high dose celecoxib with low dose aspirin led quickly to an increased incidence of VTE. And this was possibly due to competitive inhibition of aspirin at platelet receptor sites. This interaction was mitigated by altering the administration times of both medications. And so from that point forward, aspirin was administered at least 2 hours before celecoxib. We had no further VTE events occurring once we changed these administration times. And all of our patients are educated to continue this practice after discharge. So there are multiple advantages of performing risk stratification with the CRS. The CRS includes all vital risk factors for postoperative VTE, including detailed personal and family history. And risk stratification obviously relies on accurate history. But the CRS is a dynamic tool, so that changes in clinical status of the patient can change the CRS and potentially the choice of chemoprophylaxis. And this actually occurred 7% of the time in our validation study. Specifically to our patient population, this includes the inability to ambulate 30 feet continuously, receiving a blood transfusion, inability to fully weight bear with no contraction of calf muscles with ambulation, or the introduction of a brace or a cast. And the CRS has allowed us to incorporate the increased risk of hypercoagulability after COVID-19 infection, which obviously was a huge concern for us when returning to elective surgery.
In 2023, Chow and his group published a study, the validation and modification of the Caprini Risk Assessment Model for evaluating VTE after joint arthroplasty. This study actually supported the validation studies of Dr. Krauss and his group. And the study looked at 3,807 patients, in which of which they identified 432 VTEs. All of the patients were interviewed by the investigators. This assured that all personal and family history of VTE or thrombophilia were captured. All patients underwent preoperative and postoperative ultrasound screening. There was significant correlation between the incidence of VTE and the Caprini score. A CRS of greater than or equal to 9 is considered the high-risk threshold for postoperative VTE. The lower threshold, a CRS of 9, determined in this study, versus Dr. Krauss's group, a CRS of 10, could possibly be related to the routine postoperative ultrasound surveillance for DVT, which was done in the study, which is not standard of care in the United States. So in conclusion, the current publication emphasizes the importance of the Caprini risk score in total joint arthroplasty and provides further evidence for the use of anticoagulants in the highest risk patient population.
In conclusion, risk stratification to choose thromboprophylaxis after joint arthroplasty allows for safe and efficacious medication choices. The use of the CRS to guide therapy choices led to a reduction in annual overall VTE events from 0.78% to 0.2%, and we have maintained that at 0.4% annually since. Risk stratification is dynamic in nature, and for optimal outcomes, accurate ongoing patient assessment is paramount. The CRS is an effective risk stratification tool to identify low-risk patients who can safely be prophylaxed with aspirin 81 milligrams twice a day, and also high-risk patients who require more aggressive thromboprophylaxis after arthroplasty. Thank you very much.
Thank you very much for the remarkable presentation by all of you. And at this point, I would like to just ask a couple of questions. The first question I would like to know is, how do you get sustained? This program has been sustained over time, and yet there are people in your institution, there was a recent publication, that don't buy into this. I don't understand that, because what was shown, not only did you lay the groundwork for this, but then the Chinese did this study where they scanned everybody, which you don't do in normal practice, but it gives you the true incidence of VTE. They also looked at all of the factors. So when it's all done right, they verified your program. We've done the same thing at North Shore in Evanston, at the Skokie Hospital, and also the same thing has been done, believe it or not, at the Bozeman Deaconess Hospital in Bozeman, Montana, on the orthopedic service. Dr. Krauss, can you shed some light on this?
Well, let me just say something that, sometimes you have something that is really wonderful and you just can't convince the rest of the world that it really is true. I mean, we find that in everything in life, On the other hand, we try to lead by example, meaning that we believe that knowledge is power, especially when you are sharing that knowledge. So in our own institution, we have, a team that is really looking at the data and publishing the data. Every single patient is followed up. And then we publish that data and I'll say, look, we're going to make a change in the protocol because these are the findings over the last 1,000 patients. And we share that with everybody. And there's those surgeons that say, gee, I'm not going to do that. Just because Dr. Krauss is doing it, I'm not going to do that, And yet what happens over a period of a few months or a year, they all come back to us and say, how come Dr. Krauss gets so much attention from this team? They seem to be following all of his patients and implementing the protocols, and his outcomes are better. And then the answer is simple. Well, this is open to everybody. Why don't you join us? We can follow your data as well if you follow the protocols. And so we've managed to convince many people that were initially skeptical, because most surgeons, for whatever the reason is, don't want to do what the other guy is doing. But when all of a sudden they realize that you have a real multidisciplinary team that is helping the surgeon provide better outcomes for his patients and therefore improve his personality and his outcomes and his reputation, then they're willing to adopt it. On the other hand, as you see in everything in the world, we're not going to convince everybody.
Well, thank you very much. I think that's been a very, very thorough and open answer. And I would like to say that I believe that cream rises to the top. And as we're starting to see various institutions from different parts of the world, the American West, China, the Midwest, East, that this will sort itself out. And the problem that I see, and I've seen so many publications like this in the orthopedic literature, people say they're using the score, but they don't ask all the questions at the right time. I'd like to point out to the audience the fact that what was said here about having the patient do an initial scoring and then having the person responsible for the history and physical of the patient complete that and verify it. That's key. Not the floor nurse, not the same-day surgery nurse, not anesthesia, not just before you go into surgery, not even with a surgeon's interview, because there are other things to discuss at that time. So that's a really key point. So I'd like to thank all of you for a wonderful job and a brilliant presentation. And I would say that in conclusion, your group has presented for us the benchmark for the nation for orthopedic total joint replacements. Thank you very much. And I hope everyone has a wonderful day.
Thank you.
And thank you very much for all the guidance and assistance that you've given us over these many years. This would never have happened without you.
Yeah, it's all due to forces above and beyond. Thank you very much.
You're welcome.